Good evening, everybody. Can you hear me?
Yes.
Yes.
Yes, we can hear you.
Excellent. Okay. Welcome. I'm not sure we've got everybody, but we look like we're pretty close. My name's Mike Grocott. I'm a professor of anaesthesia in Southampton in the UK and one of the directors of evidence-based peri-operative medicine. So thank you very much for joining us for this abstract session. I'm going to switch now to a PowerPoint presentation which has a few introductory comments, and then it's got each of your presentations within it. So hopefully that will work if I share screen. No, that's the wrong one, sorry. Give me one moment. Good, so we're there. I'm just going to quickly skim through the presentations and hope that we've got everybody here. So, sorry, I'm going to... Dr. Sapru?
Yes.
Great. Dr. Agrawal?
Yeah, I'm there.
Great. Dr. Potter?
Yeah.
Great, thank you. Dr. Robbins?
Hello.
Lauren Robbins? Can you hear? Are you muted?
Yep, I can hear you. Can you hear me?
Fantastic. Thank you. You're quite quiet. I don't know if you can make yourself a little bit louder.
Okay, yeah, we'll try to do that.
Dr. Davies?
Hello.
Hi. Dr. Gao?
Yeah, hi.
Hi. Dr. Luney? Dr. Luney? Catriona Luney, can you hear me, or is it one of your colleagues? Okay, we'll come back to that. And then Dr. Parviz.
Yeah, I'm there.
Fantastic, that's it. Okay, so we skip back to the beginning. First of all, thank you very much for submitting your abstracts. The poster presentations are from the posters that you presented. You have 6 minutes each. Ideally, we have some time for questions, so if you could keep the presentation down to 2 or 3 minutes, we'll have more time for a bit of conversation. If that happens, I will ask a question or two, but also feel free to ask questions of each other if the time is available. And of course, as I'm sure you will, that can be constructive of your colleagues on the presentation. As you probably know, the 3 finalists have already been chosen, and they will be making oral presentations on the main EBPOM stage, the main virtual EBPOM stage tomorrow to get the winner. And then finally, I hope you can join us over the next 2 or 3 days for the virtual EBPOM Chicago meeting, and then subsequently for we have our virtual Dingle meeting. We don't actually go anywhere anymore. We just sit by our computers, but we still call the meetings by the same name. We have a Las Vegas meeting early in the new year, and then the main EBPOM London meeting next summer in early July. So thank you very much for joining us. I'm going to move straight to the presentations. I'm just going to get my timer sorted out so everything is nice and equitable. So Dr. Sapru, when you're ready, please start.
Okay. Good evening, everyone. I'm Dr. Sapru, working in Northwick Park Hospital. I will be presenting a case. This is basically a case report of a patient with a severe left ventricular dysfunction who came for a liver transplant and had an implantable cardioverter defibrillator which was implanted before the surgery. So he was a 59-year-old male with a history of hepatitis C, chronic liver disease, and hepatocellular carcinoma for liver transplant. when he came for a workup for the liver transplant, he had a proper workup done, which included an ECG, an echocardiograph, coronary angio, which is the usual workup done for these patients. And on ECG, he had a left bundle branch block with atrial fibrillation, and on echo, he had a global hypokinesia with an ejection fraction of 35%, moderate MR, pulmonary artery systolic pressure of 35 millimeter mercury, and dilated left ventricle with biatrial enlargement. Because of these because of these findings, he had a further workup done, advised by the cardiology team. He underwent a coronary angiography and Holter monitoring. On coronary angiography, he was found to have a non-critical coronary artery disease. 24-hour ECG Holter monitoring showed ventricular ectopic activities with ventricular premature contractions and atrial fibrillation. In view of on history and clinical assessment, the patient had a good exercise tolerance. He was not very symptomatic, and he had a good independent lifestyle. And he was worked according to the liver team. He had a child CTP score of 6 and a tuber MEL score of 22. So, and also according to the Milan criteria, he was suitable for a liver transplant in terms of the hepatocellular carcinoma. So there was a multidisciplinary team decided, the anesthetic team, cardiology team, hepatic team, all had a joint decision. And the cardiology team, after reviewing the findings, they decided that an implantable cardioverter defibrillator should be inserted in this patient in view of, mainly in view of management for the post-operative management of this patient, because it's quite a major surgery, and in order to cope with the post-op stress, it was decided by the cardiology team to implant this, and it was implanted a day before the scheduled surgery, and it was programmed through the VVI mode, and the patient was started on diltiazem medications for the same. On the day of surgery, the patient was taken up for surgery. He was seen by the cardiovascular.
We've lost sound a little bit, Sindhu.
Can you hear me now?
That's better, thank you.
Yeah, sorry about that. So the patient was taken up for the liver transplant and seen by the cardiac physiologist on the morning of surgery. His ICD was programmed to a VVO mode, and we had external defibrillator pads attached to the patient and a defibrillator standby, as well as an intra-aortic balloon pump standby in the operation theater. We did our usual checks, and the patient was taken into the pre-anesthetic room. He had an IV line inserted, standard monitoring was done, and the patient was induced with etomidate and opioids that included fentanyl for induction, followed by a rapid sequence induction usually done for these patients, and there was an arterial cannula put. After intubation, after induction, the patient was, we put a central line and an advanced venous access. A baseline trans-esophageal echocardiography was performed for the patient before the surgery started. And the usual infusions included fentanyl, rocuronium, electrolytes infusion, or adrenaline, which is the standard that is usually done. And of course, a diltiazem infusion was continued during the surgery. Hourly ABGs were done to maintain normal acid-base balance and electrolytes. Cardiac output monitoring was used, and goal-directed fluid therapy was used for the patient using clinical parameters as well as stroke volume variation. The usual procedure, the usual surgery went on, the dissection phase and hepatic, everything was uneventful during the implantation phase. And after reperfusion, the patient it was uneventful for the patient and he required minimal inotropes during the reperfusion phase. The TEG did not show any problems. He did not require any blood products, and the subsequent ABG after implantation showed a good graft function. So after checking all his acid-base parameters and electrolytes, making sure that everything was normal, the patient was shifted to the ICU for post-op management on ventilatory support with minimal inotropes. In the ICU, the implantable cardioverter defibrillator was assessed by the electrophysiologist and it was turned on. The post-operative course for the patient also was smooth, that he was extubated the next day and
keep going with that's 6 minutes, but we have a little bit of latitude.
Okay. That's it. I'm almost done with that. So basically, from this, we learned that the patient, that judicious, in cases of liver transplant, we have to have judicious fluid management, avoid volume overload, which can precipitate heart failure. We have to maintain a good preload, afterload, contractility of the heart. All the electrolytes, hypoxia, hypercarbia, all should be avoided. Electrolyte balance should be maintained to avoid arrhythmias, as the patient was prone to that. So we took care of all that. And blood transfusion was avoided in this patient. The post-op course was very smooth in view of the ICD, and it helped him to cope with the post-operative course. So prophylactic ICD, we can say in this patient with a decreased left ventricular function. It has been seen in previous studies as well that it is very useful for the overall peri-operative management of these patients. And of course, we had a multidisciplinary approach with meticulous monitoring and a good peri-op care, which helped this patient to cope through the surgery, and he was discharged after 17 days post-surgery.
Thank you very much. We obviously a little bit over time, so not time for many questions. But my one question, so obviously great example of multidisciplinary management. And the ICD was there, if you like, as the parachute if things went wrong, but was defibrillation either using the external pads or the ICD? Did it happen at any point, or was it there just in case?
No, we had just kept it on. The external defibrillator was a standby. He did not have any sort of significant arrhythmias at all. He was quite stable. The rest of the parameters were all managed well, so he did not have any such things. It was not required. But in the post-operative course, the device was switched on and he did not have any issues. It was functioning well and he had a good recovery.
Great. Thank you very much. Great presentation.
Thank you. Thank you so much.
I'm going to move on to the next, Dr. Agrawal, the next presentation. Start when you're ready.
Yeah, I'm ready. Thank you. Hi, everybody. So this is Amit here. I'm currently working at the Royal Blackburn Hospital in the United Kingdom. And the study that I'm presenting today is a prospective observational study, which is an original research, which was done at Jaslok Hospital, Mumbai, between 2012 to 2014. So essentially, the study was usefulness of ultrasonography for selection of the correct size endotracheal tube in pediatric patients. Now, a couple of reasons to choose this topic. So for a long time, we have been using age-based formulas to determine the endotracheal tube size. And generally, it's like we've kept a tube larger and a tube smaller ready just in case. And these formulas have stood the test of the time, because the first formula given by Cole for the uncuffed tube came in 1957. And the other formula given by Motoyama, it was in 1989. And even today, these are the most commonly used formulas, although other things such as height-based criteria, weight, and a lot of other things or indicators have been trying to determine this correct size for the tube in pediatric patients. Now, increasingly, we are seeing that ultrasonography has become almost a bedside tube today, be it anesthetics, emergency medicine, or critical care. So that was the reason we wanted to know whether ultrasonography can be used to determine the correct size tube in elective cases. So essentially, this was the aim of the study, to determine whether it's useful and then to compare it with age-based formula, whether it's superior or the same, or if there is any benefit. So essentially what was done was we had a case sample size of about 60 patients, and after obtaining local ethical committee clearance, these patients who were having general elective anesthesia had a verbal consent from the parents, and they were included in the study. The exclusion criteria involved a known allergy to the ultrasound gel, age more than 12 years, or a pre-existing laryngeal pathology, which would make this an anticipated difficult airway. Now, before laryngoscopy, the transverse tracheal diameter was measured by the operator using a linear ultrasound probe, which is 16 to 13 megahertz, also known as a hockey stick probe. So when this measurement was done, the anesthetist was supposed to do the laryngoscopy and go ahead with the case, was blinded to the ultrasound measurement, so he didn't know what the measurement was, and the measurement roughly took about 30 seconds. The operator was trained before this study was started with a radiologist in terms of taking the measurements. Once this measurement was taken, the anesthetist went ahead with the laryngoscopy, and obviously they used the age-based formula to determine the size of the tube. And obviously they kept a tube more and a tube smaller in size ready, just in case if it was needed. Again, amongst the 60 cases, we had about 37 cases in which the cuff tube was used, and about 23 cases in which the 37 in cases in which uncuffed tube was used, and 23 cases in which the cuff tube was used. So after this was done, once the patient was intubated, the endotracheal tube sizing technique was used to determine whether the tube that has been put in according to the age-based formula is appropriate or not. Now, the sizing technique meant that if we get a leak, airway leak, without inflation of cuff in the case of a cuff tube, if we get a leak between pressures of 10 to 25 centimeters of water, that would be deemed as an appropriate size tube. If the leak occurred at pressures less than 10, then it meant that the tube was too small in size and it was replaced by a bigger size tube. Similarly, if the leak pressure occurred at pressures of more than 25 centimeters, it was deemed that this tube was too large in size and it was replaced by a smaller tube. So this is how the endotracheal sizing technique gave the optimal endotracheal tube size. So now the ultrasound measurements give us a appropriate size tube, and the age-based formulas gave us another set of readings of what size of tube was appropriate. And both of these were compared with the sizing technique, which gave us the optimal endotracheal tube size, which should have been used. Now, in the results, we found that the data was quite comparable in terms of age, weight, sex, and other things. And as I said earlier, almost an equal distribution, if not exactly equal, of cuffed and uncuffed tubes. So as a whole, we found that the age-based formulas predicted the correct size of endotracheal tube in about 36 cases out of 60. That is about 60%, as compared to 53 cases out of 60 correctly predicted by the ultrasonography. So the positive predictive value of the ultrasonography was quite higher as compared to the age-based formula. And again, correlation analysis was applied, and it showed that the Pearson's correlation coefficient between the ultrasonographically determined size and the optimal size was about 0.977, as compared to a coefficient of 0.914 for the age-based formula method when it was compared with the optimal size. Again, when broken up, if we break up the age-based formula for the cuffed and the uncuffed, again we found that the correlation coefficient, the Pearson's correlation coefficient, was again higher in the case of the ultrasonographically determined tube size as compared to either the cuffed or the uncuffed tube formulae, that is the Coles and the Motoyama's formula. And we again used one more method to see whether it was more effective, which we said it was a virtual effect of the ultrasound on the number of intubations required. What this meant was, in our study, we counted the number of cases in which the tube had to be replaced. So the tube was determined as per the age-based formula, and then we replaced it as per the sizing technique. So we found that in about 24 patients, the tube had to be replaced to either a smaller or a larger size. And then we extrapolated that based on our ultrasound readings. If the operator had gone for the tube that the ultrasound method gave as the correct size, then re-intubation would have only been required, or the tube would have to be changed only in 7 cases, which means that the number of re-intubations would have been about 1.11 in case the ultrasonography was used to determine the size, as compared to 1.38 re-intubations, which we had to do in the age-based formula method. So essentially, we concluded that ultrasonography is a very useful, safe, quick, reliable, and quite non-invasive method, and again reproducible, to measure the transverse tracheal diameter to determine the endotracheal tube size in elective cases. And this study validated the superiority of ultrasound. And we thought that with increasing use, and if more people are trained to use ultrasonography, it can also become, airway ultrasonography can also become a part of the fast scan that is done for rapid assessment during trauma and other such things. Also in our study, we include, obviously this was an excluded patient, but as a part, this patient was not a part of the study, but it was a difficult airway. And because we could use only the ultrasonography in 30 seconds, we did measure the diameter in that case, and he had to, it wasn't a difficult airway. We had to put in a double lumen tube, and ultrasonography again correctly predicted the diameter in that case as well. But obviously it was not included in the study because it was one of the exclusion criteria. And the last bit I would say is it still has its limitations. It is a bit costly, not always possible to arrange the equipment, and the operator has to be trained to use ultrasonography. So overall, I think we concluded that ultrasonography is a better tool, and we need more training for ultrasonography to be used more frequently and for it to be more useful for us. Thank you.
Thank you very much indeed. Again, we're relatively over time, but I guess your final comments are reasonable, but the more that ultrasonography becomes, the cheaper it becomes, and we've now got these mobile phone enabled probes that are becoming cheaper and cheaper. It may be something that could become more routine. And I guess the obvious question is, are you, I mean, the re-intubations you described, as I understand it, were hypothetical. Are you tempted to do the study where you actually explore whether it would change the number of re-intubations?
So when we speak about the re-intubation with the ultrasonography, they are hypothetical, but the re-intubations that happened with, so the earlier, that is 24 patients, so they were actually re-intubated with an appropriate size. So so until we got a leak between 10 to 25, a tube was changed.
I guess I'd encourage you to do the randomized study and see if it really is better.
Yeah, sure.
Yeah. Thank you very much. We sadly need to move on. So the next presentation is Dr. Potter.
Hi, I've got a co-presenter here with me as well, Adam Hatoum. Is it okay if he takes the lead in presenting the poster?
Whatever works for you.
Okay.
Yeah. So my name's Adam, and as you just heard, Harriet's also on this call. We're both final year medical students at the University of Cambridge, and we performed an audit looking at the incidence of peri-operative anemia in patients who received an intraoperative blood transfusion during elective gynecological surgery. So NICE has set out in its guidance that all anemic patients undergoing elective surgery should receive peri-operative oral iron supplementation. And we set out to investigate whether this guidance was being adhered to. So data obtained from our clinical information system showed that there was a total of 63 patients who received the blood transfusion between 2015 and 2017. And 41 of these patients had pre-operative HB levels recorded, with 40 of these actually being anemic. And only 12 of these anemic patients did end up receiving the peri-operative iron replacement therapy, 3 pre-operatively and 9 post-operatively. In total, there were 126 blood units that were transfused. 60 of these units were transfused to patients with minimal intraoperative blood loss of less than 500 milliliters. 40 units were transfused to patients who did have preoperative anemia, and only 6 of these units were given to patients with an HB of less than 80 grams per liter, which is the transfusion threshold that's recommended by NICE. In 74 of the units transfused, the post-transfusion HB level was over 100 grams per liter, which reflects quite a generous treatment margin. And in conclusion, the incidence of preoperative anemia in this patient group was quite high, with only 30% of them actually being treated with iron preoperatively as recommended by NICE. And we think that this is likely contributing to the need for blood transfusions. Many patients, as we said, were transfused at a HB level far higher than the threshold recommended by both NICE and the American Association of Blood Banks, which is 70 to 80 grams per litre. And as we said, almost half of the units transfused were given to patients with minimal blood loss of less than 500 millilitres. The NICE guidance advises that treating anemia with iron supplements can reduce the need for transfusions. And obviously this has many benefits. It can avoid serious risks that are associated with blood transfusions, such as infection, fluid overload, and transfusion reactions. And it may also reduce the length of hospital stays and thus the cost burden to the NHS. Our next steps going forward, obviously having been sidetracked by the current crisis, is to present our findings back to the anaesthetics department and re-audit further down the line, and hopefully we would hope to see some more adherence to the guidance. Yep, thank you, and obviously welcome any questions.
Thank you very much. Very nice presentation. We've got a little bit of time. This is probably an unfair question, given I'm sure you've had a pretty busy year with COVID and everything else. Did you happen to see any articles in the Lancet last week?
No, I did not.
So the reason I raise it is because when you present this back to your department, the PREVENT study, which is a randomized controlled trial of peri-operative intravenous iron therapy,
okay,
you know, obviously of relevance to this area, was published last week, and it might be worth a peek. And on the face of it, appears to show no difference, but I would have a look at the length of stay and complications data, because it may be helpful to your case if you're encouraging them to embrace pre-operative anemia management more enthusiastically. And were you looking at your seniors, if you like, the doctors, were you surprised that they were so non-compliant with the recommendations in terms of transfusion thresholds?
Yeah, so that was the one point. Obviously, intraoperatively, we imagine that it's difficult to make the decision simply based off HB levels. There's a number of other factors, such as if the patient's actively bleeding.
Sure.
But we think that given that a number of the units were given to patients with minimal blood loss, so it didn't seem like they were majorly bleeding. Yeah, we would have thought that perhaps the HB thresholds would have been used more.
Yeah, I mean, it's a common finding, but it's interesting in terms of our adherence to recommendations and how behaviour matches that. Brilliant. Listen, thank you both very much indeed. Great presentation.
Thank you very much.
Next presentation, Dr. Robbins.
Hello, can you hear me a bit louder now?
Yes, brilliant.
Fabulous. So I'm Lauren, I'm a CT3 anaesthetist at Derriford Hospital in Plymouth in Devon. Essentially I have been working on a project over maybe the last sort of year or more on improving the provision of our emergency guidelines in areas where we provide anaesthesia. So this started because our department was due to revalidate its AXA status, which is the Anaesthesia Clinical Services Accreditation. One of their standards was to have up-to-date emergency anaesthetic guidelines available everywhere that anaesthesia is provided. So doing an initial audit to sort of see what we had in our theatres and in our remote locations such as cath labs, I essentially found a sort of a collection of mishmash of guidelines from various sources, not particularly anaesthetic specific or in any particularly coherent order, and several of them were sort of bunched together and actually tied to the anaesthetic machine in the anaesthetic room, and therefore kind of couldn't be ported around, which didn't seem particularly useful. The graph in the sort of top left corner, essentially the red bars, so out of 23 locations, both theatres and in the main suites and the remote locations, 3 of them had no emergency guidelines whatsoever, and that tended to be the more remote locations such as cath lab where actually it's going to take longer for help to come if you need it. And then a further 3 locations had out-of-date guidelines, essentially. So I presented this to my colleagues in the department at CME and proposed a solution or an alternative, which is in the form of the AAGBI's Quick Reference Handbook. So there's a page of that at the bottom left of my poster. So essentially this is a collection of guidelines specifically for anaesthetic crises in theatre. So as well as the usual things like anaphylaxis and advanced life support algorithms, it also has things specifically for the anaesthetised patients. So things like bronchospasm, hypotension and desaturation. So each guideline is laid out the same. They're quite easy to follow. They're designed to be read out aloud by somebody that is not immediately involved sort of in the treatment of the patient. So it might maybe a team leader type role. The black text on the left shows essentially a series of step-by-step actions to take. And then the coloured boxes on the right are call-out boxes. So those contain things like drug doses, equipment instructions, and critical changes, plus sort of pointers to other guidelines. So say your patient arrests, it will then move you on to a different guideline. So the department were quite keen to implement the Quick Reference Handbook. They liked it. So that's what we did. So the bottom right picture, figure 4, shows essentially, so I printed out and laminated these Quick Reference Handbooks, put them in folders and wall mounted them in every anaesthetic room or remote location that we have at Derriford. And then essentially about a year later, which was probably June this year, I resurveyed the department. So we were sort of in past the peak of, I suppose, the current COVID pandemic, but there'd been some changes to our practice, and we were still well aware that, or we still are well aware of the fact that there is a pandemic occurring. Essentially, everybody that responded said that they would use the handbook in an emergency. They particularly liked that it was clear, that it had a consistent layout, and thought that it was optimal to ensure that they weren't missing anything, particularly in those less frequently encountered crises, such as things like malignant hypothermia. What I thought was most interesting, so I don't know if this is the same in every hospital, but certainly at Derriford it was the norm to anaesthetise our patients in the anaesthetic room and then transfer them through to the operating theatre. It would kind of be unusual for somebody to induce anaesthesia on the table in theatre, but because of the pandemic, that is what we were sort of asked to do in order to keep the anaesthetic room as a clean area. When I asked my colleagues whether they would continue to anaesthetise in theatre kind of once things have got back to normal, if that's a thing, almost 2/3 of them stated that they would continue to induce anaesthesia in theatre, which is obviously not where the new emergency guideline theatre thingies are on the wall. So I also asked my colleagues how many of them had a mobile device on their person in theatre, which turned out to be 90% of them either having a mobile phone or a tablet in theatre. And I thought that possibly we could utilise this. So I've created a QR code poster, which you can see in the top right corner, which has been laminated and stuck on the wall next to the anaesthetic room inside the actual theatre, so that colleagues can scan it with a mobile device and have instant access on their mobile or tablet to these same guidelines. They can then save them to their device so that they don't have to repeatedly scan it the next time. And this has advantages, so in that colleagues can either have the hard copy available if that's what they'd like, and quite often I've found colleagues sat there just having a little read through them, or they can access the mobile device, whichever they prefer. It does mean that if there is a patient who is COVID unknown or COVID positive, there is no need for kind of backtracking into the anaesthetic room to fetch the folder and then bring it into the dirty theatre and sort of contaminate it, and need to then kind of wipe down and clean every single page of the folder. I appreciate probably we should be definitely decontaminating our mobile phones if they are in theatre, but that equally might be something that's easier to do. So in conclusion, we now have up-to-date guidelines in all anaesthetic rooms and theatres and remote locations at Derriford, in both digital and hard copy format. We did meet our AXA reaccreditation criteria, which was nice, and that was sort of a success for the department. And hopefully these are guidelines that can be fairly easily kept up to date, either by the production of a new QR code or by printing out whichever pages of the actual handbook have changed and slotting them into the folders. It would be really interesting to see what other hospitals in the Southwest region are doing in terms of provision of their emergency guidelines, and whether we could kind of standardise it, which would be particularly useful for trainees who are obviously rotating around the region, to have a kind of standard set of emergency guidelines that they're familiar with. Thank you very much for listening. Any questions?
Great, thank you. We're again a little bit over time. I guess the only question, which is probably unfair, is do you have any indication as to what the impact on the management of emergencies has been? So have they been used in anger, and what's the feedback been?
Yeah, so that's something that I've not yet got any feedback on, as to whether anybody has had a real sort of, you know, an unusual or an unfamiliar crisis and has actually used these. But that would certainly be kind of a next step in working out, you know, whether they are actually useful in that respect.
Great, thank you very much indeed. Great presentation.
Thank you.
Next up, Dr. Davies. Davies.
Hi.
Hi there.
So hi, I'm Miranda Davies. I'm here with my colleague Fiona Lakin, who's hopefully on the line too. And we're both anaesthetic trainees working in a 400-bedded district general hospital in Dorset in the southwest of England. And we're here to talk to you about a project or audit which is currently ongoing in our hospital, which aims to improve the quality of anaesthetic care delivered by our department to the patients. So historically, there's been a lack of consensus as to what actually defines good quality anaesthetic care, and traditional outcomes like morbidity and mortality, whilst they are very important, they don't really give us the whole picture. And increasingly other endpoints are being recognised as very important. And these things include things like patient-reported outcome measures like post-operative nausea and vomiting, as well as pain scores, along with things like temperature and if patients are dreaming, which is a new buzzword for drinking, eating and mobilizing within the first 24 hours after surgery. And these endpoints have been studied and validated in large ongoing national research trials and projects such as the PQIP or Peri-operative Quality Improvement Project, which serves as an extensive data source that we can compare our results to. And research has also shown that generation of individualised feedback to anaesthetists on patient outcomes can improve patient care. So the aim of this project was to audit how we were doing and our patient outcomes in recovery, as well as to provide departmental individualised feedback to anaesthetists about these outcomes. And this was particularly useful in a small hospital like ours, where we don't have the resources to be part of the PQIP project, but then we have some data to compare to it. So prospective data was collected for all patients that were admitted to our recovery room following anaesthesia for non-obstetric surgery, and this took place towards the end of February and beginning of March this year, though data collection is still ongoing, but processing has been sort of stopped because of COVID. Data was collected by the recovery staff whilst the patient were in recovery, and it was inputted into a data collection tool which we created, which can be seen on the poster there. And this data aimed to reflect data that was being collected in the PQIP project, so we could compare our data against that. and it included information like patient demographics, type of anaesthesia, temperature, and then patient-reported outcome measures, whether they were dreaming, and other things like whether HbA1c had been checked in diabetic patients, whether our patients were anemic going into surgery, and whether a pre-op risk assessment had been taken. And then results were compared to PQIP data, and individualized summaries were generated for our anaesthetists. And if I hand over to Fiona, she's going to talk about the results.
Hi there, my name's Fiona. I'm just going to talk you through the results of this project. So in total, we analysed 408 patients that came through our recovery with an age range of 4 to 101, and with 48% of those being male. A variety of specialties, predominantly the majority were orthopaedics and trauma, but also general surgery, ENT, urology, gynaecology, and a very few ophthalmology and max fax patients. As you can see on the poster in the third column, the majority had general anaesthetics, with 50 having a regional and around 40 having a combined regional and GA, and with about 2/3 being elective and 1/3 being emergency. So in looking at our results, 100% of our patients were normothermic in recovery, and actually our PROMS data was superior to the PQIP data, although bearing in mind that our sample size is significantly smaller than PQIP. So we had the same, roughly the same shivering. Our pain scores were better in recovery. Sore throat was down significantly compared to PQIP. Less confusion was documented, and about 2/3 less, of post-operative nausea and vomiting. However, looking at our dreaming status, we're doing worse than the national data on this. So if you can see in this third column, the table at the bottom, so 66% were drinking in recovery compared to 78% in the PQIP data. 46% were eating compared to 60%, and then only 40% mobilising compared to 78%. We did find that 9% of our patients had a pain score of 3, which was in line with 11% in the PQIP data with severe pain in recovery, and no significant difference in the outcomes between our individual anaesthetists were identified. So in discussion, looking at these results, the department performed well in PROMS. The dreaming data was fairly poorly recorded by recovery, but it does look like the national, we're not doing as well as the national standards or figures. However, patients were followed up for 24 hours in PQIP, and we just don't have the resources or the staff to follow our patients at 24 hours. So this is kind of within the hour or so that they're in recovery rather than 24 hours, which may be the reason for the significant difference that you see here. But as a result of this data, we've instigated a sticker which is going in the notes to try and improve the dreaming status post-op, as a little reminder to the staff and the wards to encourage these things. The data looking at anaemia and pre-operative risk assessment and HbA1c was very sparse and represents an area that we really need to focus on and improve the data collection for. With the pandemic kind of past the current peak, we're looking at re-educating our staff and talking through what data we want registered on the form, and looking at the form itself, if there's any improvements we can make to make that easier for collection. In terms of the individual anaesthetists, there weren't any specific differences, but as I say, our sample size is quite small, and that's partly due to that, we think. However, with ongoing data collection, we hope that over the course of the next few months, up to Christmas, we may have bigger numbers which will enable us to give better and more detailed feedback to our individual anaesthetists within the department. And with the aim to kind of produce an annual review for each anaesthetist and feedback for clinicians, which may form part of their appraisal if that's useful. We're looking at developing a kind of computerized entry system, which will make things easier for both data entry but also analysis, and will allow us to analyze our results in more kind of real time rather than the lag of us having to input the data, which is in the process of being going through IT and being looked at by our IT department, and in hope that we may be able to roll this out possibly across a couple of hospitals within our deanery to try and help collect data across the deanery and help us compare each other across the Southwest. So in conclusion, looks like at DCH we're not doing too badly compared to PCOP data, although our dreaming status can be better, and improvements in this are ongoing. We'd like to improve our data collection so that we can get better data collection and allow better measurement, and we're ongoing work on this digital tool to allow us to collect better data entry and facilitate analysis in a more real time. Thank you. Any questions?
Brilliant, thank you very much. We're probably a little bit short of time for questions, but very interesting presentation, and yeah, keep going. It's encouraging to see some of your results substantially better than the national data. So thank you.
Thank you.
Next is Dr. Gao.
Yeah, hello there. My name is Pallavi Gaur, one of the senior clinical fellows working in Imperial College Healthcare Trust, London. So my topic is also based on the implementation of Quick Reference Handbook designed by Association of Anaesthetists Greater Britain and Ireland using the simulation technique. So I would like to highlight with the introduction that, as we all know, dealing with anesthetic emergencies requires a very high level of preparedness, execution, and teamwork to improve the patient outcomes and save lives. Quick Reference Handbook designed by AAGBI is one of the such simple and clear aid in dealing such crisis. It not only provides the visual aid at the time of crisis, but also helps in reducing the cognitive burden in such a stressful time. So we aimed to review the standards that were already in place at Charing Cross, where the anesthesia is provided, and compared with the standards designed by Royal College of Anaesthetists as per the guidelines for the provision of anesthetic services, GPAS, and also AXA, and highlighted that there is a need of Quick Reference Handbook, which should be up to date as the greatest tool to be accessible at all sites, and also to implement this use usefully, smoothly. So my objectives were in the following orders. One was to review the current practice which is in place. Second is to present the gap analysis of the locations where guidelines are not immediately available and a plan to implement Quick Reference Handbook as a solution. The third was to ascertain the knowledge and awareness among our anesthetic consultants, trainees, and outpatient department practitioners that are ODPs about to ascertain their knowledge about the location of these guidelines, the location of these emergency drugs and equipments, and also their pre-existing views about the utility of Quick Reference Handbook. The methodology also was framed in the following steps. After taking the audit approval from the Institute's audit committee, we developed a quality improvement methodology using the Plan, Do, Study, Act cycle, and in the following step-by-step order. As I've already demonstrated through my objectives, the methodology follows the same. Step 1, to do the preliminary survey to find out the current provisions according to the standards. Second is to do this online survey to ascertain the knowledge and the confidence regarding dealing with these emergencies using the guidelines and accurate locations among our anesthetic colleagues and the nurses. The step 3 is to roll out the Quick Reference Handbook as a solution after interpreting the results from step 1 and 2. And step 4 is to use a simulation-based learning and teaching for our trainee staff and the nurses for the easy use of Quick Reference Handbook. So I have divided my results as per the steps above. So the preliminary survey showed a major deficiency of these emergency guidelines at our anesthetic sites. They were only at 10 sites out of 20 of the main operating theaters, and all were not up to date. And out of those 10 sites, there were also very many missing guidelines and they were not as per the standards. There were no guidelines available at the remote sites like intervention radiology, MRI, and CT scanner rooms. and also not at the accidental and emergency areas where the anesthetists do need to go for an emergency intubations and rescue. My online survey in terms of the awareness and understanding and the knowledge about the management of anesthetic guidelines was divided into the three main criteria. One is to find out whether they know the locations of these emergency drugs and equipment. So as we know, this has been divided into the core emergency equipment, which includes your cardiac arrest trolley, pacing defibrillator, and airway rescue trolley. So my results showed that more than 90% of our consultants and ODPs knew the exact location of these core emergency equipment. However, only 2/3 of the trainees knew about their exact locations. In terms of our use of the emergency drug kits like dantrolene kit, intralipid, and anaphylaxis kit, there was a lot of discrepancies and people were not sure about the exact locations. Because as you know, these drugs can be found in the fridge, can be found in a particular location like recovery, so they were quite uncertain about that. And the poorest performance was among our trainee colleagues because of the COVID reasons and the situations which are so dynamic. The people were unsure about the exact locations of these drug kits. And we also found out that there is a lot of discrepancies in locating the equipments like ultrasound, video laryngoscopes, cricothyrotomy kits, and other airway rescue devices among all groups, because they thought that the exact location is your anesthetic storeroom. But basically for emergency purpose, we have highlighted that there is an emergency corridor where all the accessible emergency equipment are available. In terms of the knowledge about the anesthetic emergency guidelines, only 50% of the total respondents knew the correct location of the guidelines. And out of those, they were very familiar. If we found out the familiarity of the anesthetic guidelines, people were quite familiar about these ones, but only 50% of our total cohort knew about the Quick Reference Handbook, and surprisingly, anesthetic consultants were never used this Quick Reference Handbook before. So in conclusion, we showed the deficiency to the department, highlighted that there is a need of Quick Reference Handbook. As you show in the picture, we implemented Quick Reference Handbook at all the anesthetic sites and did some simulation training initially, and later on formulated a video to depict the simulation scenarios of a critical incident using the Quick Reference Handbook, and use this as guidance for our new trainees at our induction time. And therefore, I would like to carry forward this project to the different sites of the Imperial Trust and implement this as a guidance and use it efficiently. Thank you so much.
Great, thank you very much indeed. Again, not a lot of time, but just listening to you, with the notion of a digital version that's on devices, I wonder, I mean, your comments about not being able to find drugs or not knowing when drugs were, I wonder whether local editions of the digital version could have a straightforward click to where the drug is or where the device is that people can then go straight to.
Yes, of course, but we don't have the digital system for finding out the drugs and the locations, but definitely that's a good point that we can implement later on. And I have just got the idea from my other colleague who has presented the topic on Quick Reference Handbook that the QR code is an easy and beneficial ways to, you know, assess the whole handbook in hand. Great, thank you very much indeed. Thank you so much. Oh, sorry, jumped too ahead. Next one is Dr. Is it Luney?
Hi, yes, can you hear me now?
Yeah, go ahead.
Brilliant. My name is Catriona Luney. I undertake this project when I was working in Oxford as a core surgical trainee in orthopedics, currently an education fellow. So this is looking at thematic analysis of perioperative medicine in trauma and orthopedics. So the Nuffield Orthopedic Centre in Oxford, where the study was undertaken, is primarily an elective orthopedic centre. It does also have emergency care for patients with infected joints, sarcoma patients, plastic patients, periprosthetic fractures, and semi-elective revision arthroplasty. But the vast majority of our work is normally elective. During COVID-19, as you'll all be aware, all elective operating was cancelled, and therefore we were repurposed to manage neck femur fracture patients coming straight to us and post-operative orthogeriatric patients who had had their trauma surgery at our major trauma centre across the road in the Drum Radcliffe. Before COVID-19, we had no medical cover directly on site. All of our medical care was provided either remotely via telephone and our shared electronic patient record system, or it was provided by orthopaedic trainees like myself. However, with the change in demographic of patients with COVID-19 and our new patients coming to our centre, we had peri-operative medicine introduced to the Nuffields, and that was provided by peri-operative consultants and registrars. So we therefore decided to do a retrospective thematic analysis to see what input that had provided during the time. So we looked at all the electronic patient records who were admitted during a 10-week period during the COVID pandemic, or the COVID-19 pandemic. For these patients, we excluded any patients who were day case admissions or admitted under rheumatology, or those patients who were admitted with a proximal femoral fracture. The reason for the latter being that those patients are managed under a best practice tariff, so they should have medical input regardless of their other physical needs. Looking at the patients, we looked at the reason why they were admitted, their age, length of stay, and then whether it was a proactive or reactive peri-operative medical review. And by that we were meaning, did the peri-operative medical team have a look at the patients who are admitted and see they have multiple comorbidities, they will need input, or was it reactive, responding to a call from the orthopaedic team for advice or review? We also looked at 30-day mortality, COVID status, and how many calls were made to the medical team out of hours, which would be normally what we would do pre-COVID when we didn't have peri-operative medicine. So looking at the results, we identified 59 patients. As I said, there were a lot of patients that we looked at. The vast majority of them were proximal femoral fractures, so they were excluded. The reasons why these patients were admitted were mostly post-operative trauma, but also some of the more standard procedures that we would normally be undertaking at the Nuffield. So periprosthetic fractures, sarcoma, and the semi-elective revision arthroplasty of the lower limb. We had 52 patients who had a proactive review, and the remaining 7, it was being invited, the peri-operative medical team were invited to see the patient. The mean age was 82 years, but we had a considerable number of elderly patients in that cohort. Length of stay varied between 1 to 28 days, but with a mean of 10. And during that period, we found that 31 patients developed medical complications, and the second graph breaks that down. We had 7 patients who developed COVID during that admission, but other complications, which we categorized purely as medical complications, were UTI, delirium, anemia, a hospital-acquired pneumonia, ranging down into PE, and some cardiac conditions and complications. During this period, we had 3 patients who died during the admission and 1 patient who died within 30 days of discharge. 10 patients had calls to the medical team across the road at the Drum Radcliffe out of hours, and 3 of those patients were then transferred across to the medical hospital. The reasons why people were calling the medical team out of hours, again, is listed in the 3rd chart, and a lot of that was just because patients were considerably unwell, or questions due to COVID, or needing specialist input from psychiatry or endocrinology. With regards to discharge, vast majority of patients, the most common discharge destination was home, followed by a community hospital. In summary, looking at the input that peri-operative medicine has provided, it was a huge help and a huge benefit, and we're so grateful for all that they've provided within our department. But we did identify that 53% of patients developed medical complications, and that there was a 30-day mortality. When you then exclude those who died due to COVID-19, that drops down to 2%. So in summary, semi-elective orthopedic surgery and admission following trauma in the elderly population is associated with a high morbidity. And we've demonstrated through this study the importance of having that peri-operative medical input. And this is something we're going to take forward to ensure that we can provide in future in the department. Thank you.
Great, thank you. Thank you very much indeed. And just so I'm clear, so the 59%, so when you, to get from the 654 patients to the 59 patients, that's because you selected older patients who are having particular types of surgery?
Yes, so we excluded patients patients who were admitted due to the periprosthetic or the proximal femoral fractures because they were due to be having a medical review anyway, and we excluded the young patients. So it was looking more at the orthogeriatric input from that perioperative medicine. So I appreciate it from quite a large number of patients admitted during that time to then a small number that we were specifically looking at. We have then subsequently looked at the proximal femoral fracture cohort, but that's as a separate study.
Sure. Thank you very much. And apologies, we don't have time for more questions. I think we have just one more presentation. I apologize that we're overrunning a little bit. Completely understand if people do need to get away, but I encourage you to stay for Dr. Parviz' presentation. Dr. Parviz, please go ahead.
Thank you, Mike. My name is Khurram. I'm one of the senior clinical fellow at London Northwest University Health NHS Trust in London. I want to present this audit we did in our trust about the documentation of consent for neuraxial block. Going on to the background, providing an clear and accurate information to the patient is most important for an anesthetist. Whether the consent is taken orally or written, anesthetist needs to document between the both conversation between patient and the doctor, whether what are the interventions to be done and what are the discussion has been agreed. That has been outlined in the AAGBI guidelines and recommended set by Regional Anesthesia UK. Because of the limitations faced by an anesthetist in pre-operative visit because of the time duration, so we want to check out what are the discussion, what are the consent has been taken by an anesthetics pre-operatively for any neuraxial block. So we did this retrospective audit, who has been given a neuraxial block and what are the documentation has been taken. And the cases were obtained from the anesthesia chart, what are the documentations. And the parameters we checked was according to the AAGBI recommendation, whether any consent was taken, procedure was explained or not, benefit explained, or any another choice was given, and risk was explained, and any other further questions was answered or documented in the sheets. So we were able to get 50 charts retrospectively. Out of that, 2/3 were for spinal anesthesia and rest were for epidural and combined spinal and epidural. And result shows that the compliance was quite low, and it shows that the consent was taken in just 74, documentation of consent was just taken in 74%, risk was explained in 78%, procedure was written in 84%, and benefit was given in 30%, and other choice was given in 30%. So, and most of the documentation and as you can see in the graph, the risk, most common the risk was given for the direct or temporal nerve injury, and around 30% they return as an headache, paralysis, failure of the spinal, any bleeding chances, and infection. And less than 10% documentation was for partial block, itching, urinary retention, backache, shivering, cardiovascular collapse, nausea, catheter break, and numbness. So we presented this audit in our clinical governance meeting. It shows that there was documentation was suboptimal and the documentation was variable, and there were more risks discussed than the benefit or alternative was given, and document understanding and questionings were quite poor. And so we came to the conclusion that the reason for this variability might be because of there is no clear-cut documentation before preoperatively, and individual patients might prefer to have some less information or more information. And there was a limited space on the anesthesia chart record or less time for during the pre-anesthetic evaluation and documentation. So we given some recommendations. What are the things we can do for improving our documentation? We came to conclusion. We came with idea of preparing a video that can be showed before the preoperative visit, or there should be some pamphlet that can be given to the patient and they will have all the details about what are the things will be done, or some presentations can be done just before the operation before they go into the theaters, what are the things to be done, so they are aware what are the things we are doing in that. So we came for an action plan to create this document, so that it contains whether the procedure has been done or not, and whether any contradictions are there, and benefit, what are the benefits has been explained, and the risk, what are the minor risks and major risks, whether it has been explained, and the consent was obtained, and further discussions whether what has been done. So that it provides that it could be a medical legal or consent form that can be easily stick onto the anesthesia chart or any documentation, so that it has an consent, all things has been explained and patient is aware of that. And we will mostly we are in a plan to create this chart, and we want to re-audit whether the documentation has been improved or not. Okay, thank you.
Thank you. Great project, and I hope. Well, look forward to seeing the re-audit when you see if the stickers work for everyone. Now we've overrun time, so if you'll excuse me, I think we won't do questions, and apologies that we have overrun. Just really to thank all of you for joining us, for putting the time into making your presentations and to giving them today. We welcome any feedback. So if you've got any feedback, please feel free to email us afterwards, or drop something into the chat now. But overall, thank you for joining us, and I hope you're able to join us for some of the rest of the meeting over the coming 3 days. So thank you all.
Yeah, thank you, Mike. Good day.
Bye-bye.
Thank you.
Thanks.